The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome once again to this week's episode of the Pediatric Lounge. With you, your co-host, Dr. Herb Bravo. Today, we will be interviewing Dr. Rogu, who is the co-founder and host of the Pediatric Lounge, a practicing pediatrician, president of Long Island CIN, and partner at RBK Pediatrics. He's also an avid classic rock guitar player and chief evangelist for independent pediatricians at the national level. Our topic today are CINs, dashboards, and margins. Hi, George. How are you this Tuesday morning?
How you doing, Herb? Tuesday, once again, here to elevate great physicians and what they do.
Awesome. So we're going to do something a little different today. We're going to put you in the hot seat.
Okay.
And we're going to dig a little bit into one of your ventures, the clinically integrated network that you call Independent Pediatric Collaborative of Long Island.
Correct.
For short, we'll call it CIN. What is a CIN, George?
A CIN is what it stands for, Clinically Integrated Network. It's, I think, the new darling. It's like a IPA, but it's not an IPA. It's like a single tax ID number or a large group, but it's not a large group. The idea is to gather independent practices that are working in their own silo, wrap them up into a centralized, quality-based organization that's based on value-based contracts and wraparounds. And the end result is to bring people together, perform good quality medicine, and eventually generate some margin for the practices. Otherwise, they would have to join a hospital system or an IPA to get these benefits, and basically they don't have a voice at the table, especially if they're pediatricians.
So you said something that some of our listeners may not be familiar with. What is a wraparound contract?
A wraparound contract is, everybody has their fee-for-service contracts. Anything that's like a pay-for-performance or quality-based or value-based contract, that's in addition to a physician's practice's fee-for-service contract. So it's a second contract that does not directly go to the practice. It goes to the central entity, which is the CIN, and then and they extend it out to the member practices.
And do insurance companies, there's basically 4 large health plans in the country left: Cigna, Humana, Blue Cross Blue Shield, United Healthcare, and Aetna CVS. Do they call your office and say, hey, I got a wraparound contract for you?
That's a misnomer. A lot of physicians think that the insurance companies should reach out to you and say, hey, let me give you some money, or let me give you updated contracts with fee schedules. Why would they do that? I had asked them once that question. So why can't you just tell the doctors that they'll get a better rate? And the answer was, why should we? If they come to us, we'll do something and they prove some good quality, then they might give you a better contract. But otherwise, you can't expect the insurance company to say, hey, you're such a good person, let me give you more money.
No, but I think some physicians think that
that's
the ethical thing to do, and that's never going to happen. So your CN does 3 things really well, right? So they do 1, quality really well.
Correct. The quality is what is at the core essence of the project. So when you negotiate with an insurance carrier, they used to talk about, if you have a large number of physicians together that control a lot of lives, then another entity such an IPA can go to an insurance carrier and say, hey, I have 350 physicians. Let's get a good contract for them and we can messenger it out. They don't negotiate, they just messenger the model. So if the insurance company wants to be nice and give a better contract, then they can do that. But what happens is it stays at the IPA level and you're just another member of the IPA. You don't have any direct access to anything.
And the second thing that you do really well is, because you do great quality, which is what we all want to do, is then you're able to negotiate either the wraparound or better reimbursement rates on the fee for service.
Well, it's always been about quality. I think physician groups used to think just because I'm a physician, I just deserve better rates. You have to prove to them, why do you deserve better rates? So it always circled around quality metrics. So if you can prove that your good quality will eventually reduce the amount of expenditure for the insurance carrier, that's good quality. Then they may entertain a better contract for you. Now with the CIN and the value-based contracts, which seems to be the new future, that's all they're talking about, especially in Medicaid lines of businesses. They want these wraparound contracts because they're not going to increase the fee-for-service fees anymore. So, where everybody wants better numbers, that's not going to happen. It's going to happen if you perform good quality, and then you'll get more income.
And we'll touch on that a little bit more later on, because there's a question I have to ask you about Medicaid and Medicaid products. But the third thing that your CIN does really well is they decrease operational cost.
Correct.
And we'll get into that, but why is that important to decrease operational cost?
Because if your overhead is decreased, there's less money wasted in your own organization, which basically leads to more revenue for the practice and for the owner physicians and employed physicians. If you waste it, there's less money to be taken home. It's a simple formula.
And one thing you don't do yet is you don't have a centralized billing department for all the independent practices. Each one takes care of their own thing.
Yes, and that is by design, because if you did that, then that would make you no different than a system or a super group or an IPA or some other entity or a hospital. Whoever wants to stay independent today is fiercely independent, and they want to keep their infrastructure, their EHR technology, their physicians, their operations, their work plans. They just want to get together to do good quality and maybe get some value-based contracts that they can basically manage. They don't want to give up their tax ID number to join a super group. They don't want to sell out to a hospital.
But you don't have it yet within the CIN, but you're not opposed to, say, consulting with a group that would want to optimize the revenue cycle or that would want to improve quality or know what to measure.
Okay. Of course not. And the beauty of being part of a larger group such as this and still being independent is, the one thing that we got out of the pandemic for our CIN was this Zoom, because we get together on the first Wednesday of every month on Zoom and we talk about different things. And even during the pandemic, we got together once or twice a month, and sometimes it was every week for a while, where we just shared experiences. And what is that one doing about testing? What is that one doing about PPE? How are you keeping your offices open? The larger groups tend to figure things out faster, but if you're in a small independent practice and you're a little silo and you're the smartest guy in the room, you have nobody else to ask. So where we thought, being the larger groups, this is a simple answer to the questions, the smaller groups looked at it as rocket science.
Yes. And so, of course, I'm going to have to bring in coaching and mastermind groups, because that's exactly what you're doing. You're
Right.
getting a bunch of intelligent people into a virtual room every Wednesday with similar problems. And
Right.
so someone in that 10, 20 person group is going to already have solved that problem, and you don't have to go spend weeks figuring it out.
Correct.
That's a huge benefit, even if, you don't make $2 more off of managed care. Well, let's move on to the numbers. I want to know how many practices are in your CIN right now.
We have about 14 practices, all ranging from small independent groups to medium-sized to larger-sized groups. Some practices have 1 or 2 doctors, some have 3 or 4, some have 15, 16.
And how many pediatricians do you have altogether?
I think we have about close to 40 individual doctors, maybe a little more, 50.
And how many covered lives?
I think collectively across all practices, we have about 60,000, 60, 70,000 lives. It's a lot of lives.
That's a lot of lives, yeah.
Yeah.
And let's move on to the dashboards. I'm a data person and I love dashboards, and I love playing with computers. So for those people that are not aware of the year, we're in 2022 now, right? So what is a dashboard?
Well, a dashboard is a centralized repository of information. So they collect data from various organizations, they dump it into a database, and basically they put up pretty pictures comparing different points of information. Doctors are busy people, all right? You probably could pull all these reports out of your EHR through a spreadsheet, but then you got to look at the spreadsheets with all the cells and the lines and columns. And then if you're more sophisticated, you could make pivot tables and VLOOKUP, but that's hard stuff, all right? No doctor's going to do that. He needs pretty pictures.
And why should I care? Aren't there quality people that's supposed to do this?
The problem with the quality people is that they're not physicians, all right? They just look at things and maybe we'll go to a physician and tell the physician, you know, you should be doing more in order to get the HPV vaccine rates up. The physician, as a person, does not like taking orders from suits. They communicate, however, very well with other physicians. So what I learned with practices is you look at the quality dashboard to see where people are falling short, and then you reach out to that physician and in a polite way say, hey, we need to get your numbers up for the benefit of the entire organization so we can generate a better value-based contract and revenue. You do good medicine because it's the right thing to do. And my experience has, well, what we did is during this time, you know, the patient came in for whatever common cold, not really all that sick. We look at the vaccine record and say, oh, you're due for the HPV. Catch them at that moment in time. Do something to change your work plan for the betterment of the organization. You know, a doctor listens to a doctor, but they won't listen really to just some young suit.
No, and that's just adult education, peer-to-peer learning is much more important than listening to someone else.
Correct.
Then one thing that is just genius about your dashboard is that it's EMR really revenue cycle management agnostic.
Mm-hmm.
They get the information from the exchange files that go back and forth between your RCM and the insurance companies.
Right.
And it's frictionless, correct? I don't have to push any buttons every morning. It just gets done.
Well, you know, now we're more advanced. So some practices have a direct interface where it goes into the system and pulls the data daily or weekly, whatever it's set. Other practices have to upload what's called the 827 files, which is basically everything that happened during that encounter, every single word, every single code that gets uploaded and dropped into a database. Then we drop in the rosters, what patients we have into the database. Then we have the missing services report, which you get from the insurance carrier. Everybody gives you that, and they drop it in. And then there's also the, I think 835 is what comes back. Right. They mix it all up, and it's a live dashboard, which means that it will tell you that you have this person that's going to come in 2 weeks for a checkup. Make sure you do these quality metrics. So it's in real time. The original version of the dashboard that we created a number of years when we went live with this, it was a really, really good dashboard, but getting the data up there was complicated. I mean, you needed to have a little bit of a college degree in computer sciences to do it, because you had to download all these files that ended up in being in Excel, naming them a certain way, uploading them to the dashboard, which wasn't that hard, but there was a lot of them. And the bigger your practice was, the larger the files were. So each practice had numerous files, and getting the doctors to do this, it would have required about, 5-6 hours worth of work to upload. And, it just fell apart because doctors just didn't have the time to upload. So I needed them to upload easily for us to make the dashboards. So, we had to go to a more simplistic version of it. And we needed real time anyway, because that dashboard was historical data. So what happened in 2021, not what's going to happen in 2022.
Right. So it's very easy to use. It doesn't involve my time as a doctor on Friday afternoon when I want to get out and go grab a beer with my friends.
No, it's very easy.
That's really important.
You open it up and you look and you see the pretty pictures.
So I want to know 3 things that you measure quality wise and why?
Well, we didn't, this quality is not something that we made up. Somebody at the state level or some level designed this, and they probably did it because they felt that if we make these medical changes, the outcomes of the patient will be better in the future. And they come all from HEDIS. Everybody knows what HEDIS is.
I'm sorry to interrupt you, but I'm not sure everybody knows what HEDIS is unless they work at a hospital.
Yeah, HEDIS is a centralized quality metric organization, I think, where they decide that these are the quality metrics that we have to look at this year for the betterment of the health of the general population. And for pediatrics, it usually revolves around vaccination rates. Again, the adolescent vaccines, the HPV vaccines. The younger kids, it revolves around the childhood immunizations. You should have all your vaccines completed by the age of 2, coming in for a certain amount of well checkups by 3 years of age, by 15 months of age. The bigger child vaccination rates. I mean, those are simplistic things. You would think that everybody does it, but you know what? If you don't measure it, you don't know. You think you know.
So that's what Peter Drucker said, right? What doesn't get measured doesn't improve.
Right. But you always think you do a good job.
And we may be really smart and talented pediatricians, but we're not aware of the whole picture because we're in the exam room with one patient at a time.
Correct.
So we don't know what all those other trees are doing in our practice.
Correct.
And your dashboard shows me the whole forest that I am responsible for.
Correct. And it'll tell you should go and cut down this tree.
Right.
Or
right. And people think that we're doing really well, right? But if you look at the latest morbidity and mortality weekly report of September 3rd, 2021 on HPV rates, only 70% of the US population that's supposed to be getting the HPV vaccine is getting it.
Correct.
And the second dose, it drops off to 54%. And that's to me, I'm sorry to use this word, but it's criminal. You've already won the fight of convincing somebody to prevent cancer, but you forgot to recall them to get their second shot, and they just fell off the radar.
Correct.
So your dashboard would tell me how many of these patients that are easy, right? They already said they take the vaccine. It's just a matter of getting them back in the office for a second shot. I could win, right?
Correct. So, the idea with the HPV is the second dose, right? You would think that you got the first dose, that the parent or the patient would be smart enough to schedule the second dose.
They forget.
They forget. Simple as that. They forget. The doctors would say, well, the patient has to have some responsibility in remembering to get their vaccines. But if you do a change, little changes, like run a report of your outstanding HPVs and send out a simple recaller saying, hey, you got your first, you need your second. If you don't get your second, these are the bad things that happen if you catch HPV. Send them a story. That's what we do with recallers. We make like a little article about the different vaccines and say, you're exposed to cervical cancer, you're exposed to this, to that, head and neck cancer in boys. You already got your first vaccine, come in and get your second. Simple changes, but you got to do it. Somebody has to look, and then somebody has to figure out what to do, and then somebody has to execute.
And so at this moment, the dashboard and your CIN doesn't do that.
The dashboard does, but it requires a human to look at it.
Right.
And then that human to go to another human and say, let's get these people in somehow.
So it tells you the gap, but it doesn't use any algorithm or AI to trigger the campaign.
Not yet, but the campaign should be done at the doctor's office level.
Okay.
Because you know what, it's their patients, it's their practice. And the catch with the value-based contracts is that they put a carrot on the stick, which is a financial incentive. So if as a whole, everybody succeeds in the quality metric for the particular thing, there is a per member per month incentive that will come tied to that metric. And if everybody does good, then that money comes into the organization and it gets distributed to the physician groups.
And I'm not a big fan of the HEDIS measures, but anyhow, it just only makes sense that if they say you should do whatever it is, 10 physicals before the age of 2,
Right.
Not only is that quality,
Mhm.
but every physical brings income to the practice. So it's
Yeah,
not only you're doing good, but you're also maintaining your practice's margins by doing good, which is really great, right? When you can do good and you can go home with a paycheck,
correct.
that's really satisfying, right?
It is very satisfying, but the problem comes in, this is old culture mentality. We're so busy, we can't possibly bring in any other patients. We're leaving late. You know what? The truth of the matter is, Herb, since we started, given the Prevnar vaccine and all the other stuff, there's not so much illness anymore.
No.
So you have to fill up those spots with well visits, and the well
Yeah.
visits actually generate. You can't do 4 or 5 ear infections in an hour anymore, because you're lucky if you see 4 ear infections in a week.
Yes. Yes. Yes.
Simple.
Um, one of the sad things in pediatrics, but for me, because I love pediatric infectious disease, and that's that I fell in love with that, and that was really one of my passions in pediatrics. So it's sad because that's disappearing.
Yeah. It's
However,
on.
however, it is beautiful because there's nothing better. So it speaks so highly of general pediatricians across the country that are working every day that we have solved the problem that killed half of the kids at the beginning of the 1900s. Infectious disease are disappearing as a killer of children. We solved the problem. Now that means we're kind of working ourselves out of a job because we don't need to see pneumonia, ear infections, bronchiolitis, all these things that meningitis, measles, polio, all these things that kill children are disappearing.
Yes.
So we need to change, but that's another conversation.
Right.
I admire your leadership skills and especially your interpersonal skills, how you can get to have conversations and persuade people to do stuff, because that's an art. So when you talk about leadership and throughout the conversations we had here in the lounge, it seems that the number one thing that keeps coming, the theme that keeps coming up is relationships. How important are the relationships with your peers, other people in the CIN, and your patients to you?
I think the relationships with the physicians are the most important thing. When we started as CIN, it started because there's 2 big hospital systems in our community. One was a pediatric specific one. One was down the street, was taken over recently by one of the big networks, and they didn't have pediatrics and they wanted to get pediatrics. So what they did was they went to the other side, Hospital A, and took their entire specialty care center for one of their basically heart department, pediatrics, heart cardiology, and transplanted the entire thing into their organization. Okay. Then they probably wanted to get the other specialists, and then they wanted to take over practices. They tried to take over my practice many times, and I told them no. So then I got the people at the hospital together, and I called up all the local community doctors that I knew of, but I never knew personally. And I said, look, my group is probably big enough to weather this storm of consolidations and overtaking and mergers and acquisitions. But my fear is that you, the solo guy, the mid-sized practice, you guys are not going to weather the storm, and you're going to get taken over by the large system. And then that leaves me the only last independent group around, and we're going to lose. So I need you guys to be friends with me. Let's do something together. And we did. We built the CIN.
Yeah, so relationships are very important.
Mm-hmm. It used to be that all these groups used to be competitors. So they were afraid that you're going to steal my patients. You know what? There are so many children in Long Island. There's not enough doctors to see them. So nobody's stealing anything.
And then when you're leading, I think for you, mission is extremely important.
Correct.
Right.
You have to lead not with money. You have to lead with good medicine, good quality. And if you do that, then money will follow.
And then number 3 that I've been able to see a lot is passion. You love what you do.
Yes. It saddens me when I hear physicians say, I would never let my child go to medical school. I have the worst job in the world. You know what? I think I have the best job in the world.
Yeah.
When people, when people see you on the street, it's like they're seeing some kind of a rock star or something. People know you. Our job is nice. It's clean, especially pediatricians. Most of the time, we're respected by other entities. The insurance companies, do they respect pediatrics? I think deep down they do, but why should they give pediatricians an increase? They don't ask.
Right. And then you're very passionate that is extremely important for society to have independent practices because they provide better care, they provide competition, and they provide consumer choice.
Correct.
Once we have one system, then we will all be getting healthcare like at the DNV, wait in line and wait your turn.
Unfortunately, a lot of physicians, my colleagues, feel that a one health system is the best thing to do. Right now, at least there's a couple of different insurance carriers. I negotiate with all of them. If you show good quality, they will give you an enhancement, but you have to show good quality. Not just that I'm Dr. Rogu, slam my fist on the table, I demand more. Why?
Right.
Try doing that with a health system, a big or one organization. It's impossible. Can you negotiate with Medicaid? Impossible. Can you negotiate with Medicare? Impossible. That's it.
Right. Right. And then, lastly, it's very important. We don't like to talk about money, but margins are important, right? Because if you can't pay your staff a good salary and give them health insurance,
Correct.
they got to go work at Starbucks.
Yes.
So margins are important. We got to watch the margins no matter what, because we have a responsibility to the people that we employ who then go out in the community and raise their children.
Of course, margins are important. I mean, we went into medicine, I guess, to help people, but we didn't go into medicine to just give it away for free. People are not independently wealthy, and they're just doing this as a hobby.
We're not.
You should not be ashamed of charging for services. Lawyers are not ashamed.
No, well, we're not Catholic priests that take about poverty and live in the convent, and do good.
Right.
You could do that if you wanted to, but we're not. So we're going to talk a little bit about negotiations. And first, I want to set the stage for this because I don't think most of us understand. When I think about Medicare and Medicaid, I think of the government decides that Medicare rates are going to drop by 10% this year. Mm-hmm. And there's a factor that they multiply their RVUs by, and that's what I'm going to get paid. And that probably informs you that, I'm probably an older physician. Same when I think about Medicaid. Virginia, the Virginia legislature decides that they're going to pay 50% of Medicare rates on Medicaid, and that's what the practices get.
Right.
What has changed, and the data shows now, is that the majority, at least 41 of the 50 states, are now paying managed care organizations a capitated fee for the Medicaid population.
Okay.
And so that's why when you negotiate with these managed care companies now, your reimbursement may be different, and they have the pay for performance plans. It's not a straight, hey, Medicare rate is $100 for this. It's all you can get. Right? It's just the government's changed the rules a little bit through Medicare and Medicaid by bringing in managed care organizations to manage the patients.
Yes, they do that, and they get a per member per month fee, and then they have to engage physician practices to do good quality medicine. Now, some of them are very sneaky, where they'll blame it on the government, that the government is not paying us, so we're going to drop you down to Medicaid rates, which I found crazy because, they drop you down to 100% of Medicaid, yet they put this layer of administrative nonsense, prior authorizations, referrals with this and that, and they expect the doctors to get reimbursed at Medicaid rates. That's wrong. Right. Some of them, but most of them of today, they'll negotiate with you if you're a bigger group and you prove good quality, and they'll give you a higher percentage of Medicare. I don't think Medicaid, they're not having parity with Medicare, but they're close to it. And if the physician makes money through good quality, you know what? The insurance company makes good money too. And if there's shared savings, the insurance carrier shares in it, and so does the practice.
So we are trying to align the incentives for everybody to do good quality medicine.
Correct.
And getting away from what Medicare originally was. It was a volume-based program.
Correct.
The more widgets you do, the more you get paid.
Right.
So I was going to ask you a little more about negotiations, but really we touched on it. So when you're negotiating with an MCO or a managed care organization, they want to see quality and they want to see cost containment.
Correct.
That's what you got to bring to the table.
Correct.
Who do you bring to the table when you negotiate with them?
Well, it's best, I've learned, I mean, there's practice consultants that will do this for you or try to do this for you. But I've learned that the best project is when it's a physician-led negotiation. They, for some reason, they respect you as a physician. So they may give you lip service and stuff, but now it's your job. At least you're engaging. And you should use a consultant to be on your side to make sure what you do is totally legal and you're not crossing any lines and you're not missing anything. You know, I've done some negotiations where I thought we were done. And then the consultant says, hey, no, let's do a couple of year deal with 3% escalators. Now, I didn't think of that. She did.
That's worth money.
It's worth the money, just the escalators alone.
Right.
Whereas I would have signed off on the deal already. Because you can learn some stuff. Most physicians do not know the business end of this world. And that's why you need the consultant to do it for you. But I did learn that when you just throw a consultant into the mix by yourself to go to the insurance carrier, you're going to wait good and long. You may win, you may not win. Chances are you won't win. It's easy to blow off a doctor through the manager. And, you know, a lot of doctors will drop all these projects and push it to their office manager to do. They're not paying attention to the office manager. They couldn't care less, but they will pay attention and engage doctor.
Yes. And then, so I wanted to talk a little bit about the cost side of the equation. And I'm going to bring up my father because he's a young man. He went to England to get a master's in business administration with an emphasis in cooperative building. And most people don't know what a cooperative is, but any credit union like Navy Federal is a cooperative, and Land O'Lay, who brings your butter, is a cooperative.
Mm-hmm.
And the model is very simple. They take independent practices, providers, farmers, individuals, and they come together and they cut out the middleman and are able to negotiate better prices for their product.
Correct.
And you don't have to change who you are, right? I can deposit my money in Navy Federal. I get a better rate on my car loan than I do at the Bank of America. And I'm a shareholder on Navy Federal. And we all help each other. And it seems to me that the third pillar of your CIN is a cooperative model, where you're bringing physicians and you're wanting to help them manage cost so that they're better off at the end of the day. And you do that in several ways. So one of the things you're doing is you're buying vaccines as a group.
Correct.
And that increases your margins on vaccines, which is one of the probably number 2 or 3 expense of a pediatric practice.
Big expense,
right?
Yeah.
Then you have something that I'm not very familiar with, a PEO, which I'm not sure what's PEO stand for.
PEOs are professional employee organizations. So when you have a lot of people, you can go to one of these companies and sign up and help, and the payroll can go through there, and you can gather different types of insurances, from disability to life insurance to health insurance, as opposed to going as just in the market by yourself. So when you go to a organization with, 40, 50 different names, it's different than when you go with one name. The gang theory, the gang theory.
Right. And so, or the cooperative
Mhm.
theory, we're coming together to get some economies of scales. So within that, you're able to provide all of these independent practices with health insurance
Yep,
at a plan that is equivalent to what a Fortune 500 company would get,
correct. It could be that.
yet not paying like you are, trying to get insurance for 5 people in the
Correct.
marketplace.
Yeah, that works. And same thing for like malpractice insurance, um, medical supplies, through different organizations, because they have different tiers and different discounts. So when you go as a smaller organization to get malpractice insurance, you'll get X amount. But when one organization goes with 35 different names that need malpractice, they'll underwrite it in a different way with a bigger discount. Same thing goes with medical supplies. They have all these coupon codes. You just add this other coupon code, which gives the practices an even greater discount. I thought we had a great discount with our medical supply company because we had a bigger practice. But once we were put into the collaborative, and the collaborative was put into the discount model, even my group got a better discount on the same stuff that you do every day. It's same accounts, you just put a different discount code and everything
Right.
just changes. It's amazing.
That's right. And all those little pennies add up to big savings. So
Correct.
for many practices, health insurance for them, for the physician and their employees, is their number one expense.
Expensive. So is malpractice. So is vaccines. I mean, everything's an expense.
Yes.
So you
But
have
if
to
you,
try to trim them where you can. A little
right.
here, a little there, and you drop the overhead.
And you touched a little bit, which I think is extremely important. Um, we hear this a lot in medicine, but it's also the case in many other industries, the silos that get created. And by bringing these physicians into the same room, you're creating shared knowledge,
Correct.
which is incredibly valuable
Mhm.
for each individual of that group. Um, so we touched about that a little bit. Um, I want to know why you got involved with the pediatric lounge.
I got involved because I can never ignore a challenge. So I think we need to get a voice of the pediatricians out there, because I meet a lot of people that are doing good things. And then I also have a lot of physician friends that work for systems and hospitals and networks, and they're not happy. The amount of unhappy doctors that I meet, it just blows your mind, and they should not. And I think this narrative, this negative narrative that's out there, is created by, who do you think creates it? The systems. They want the doctors to be unhappy. They want the doctors to just go and not say anything and be a sheep and a cog in the wheel at the hospital system.
Yeah.
But they're playing. I know a lot of people. There are so many great physicians that did different things. And those are the people that need to be elevated, because if they're the best kept secret in the world, who cares? Nobody knows about them.
So we advocated our voice to hospital systems and insurance companies. And I think you're one of the chief evangelists for the concept of independent pediatric practices are good for society.
They are good for society because they can pivot, they can adjust, they can adapt. They don't have to have 15 meetings to decide on what to do,
And they give the customer choice.
Correct.
You might want to go see a group that's got 50 doctors in one office, one location, and can provide coverage from 6 a.m. to 10 p.m., Monday through Sunday, but you never see the same physician.
Correct.
Or you might want to be at a little office where there's 2 doctors, you only see the same doctor, but you know that you're not going to be able to see them on Sunday because there's no way they can pull that off.
Mhm.
But you're happy. You can, when you call the doctor because you got a problem, they know who you are, and that matters to you. So it gives people choice.
Yeah. And the truth of the matter is, we've arranged our office to be a team approach. This is the RBK way. Computer systems, templates are around about the same. some doctors have a little twist on different things. They can have their own autonomy from that point of view. They don't have to follow exactly what everybody does. But 80% of the time, it is the same. They can put 20% of the time their own twist to it. Whereas at a system, you have to click this. That's the only way to do it. You can't change. You can't deviate. This is that's on a formulary. This is the drug you should use for this particular problem. They don't let the doctors be doctors. They tell them what to do. You know, I remember we have a lot of doctor parents that come with their children, and I always see what they're wearing. So I meet this one guy that works in the emergency room, and you know, I'm talking, oh, so you working? How is it in the ER during the pandemic? What are you doing? How are things? He says, yep, I'm going to go to work today, and somebody's going to tell me how to practice medicine. And tomorrow it'll be different, and the next day will be a different system too. I mean, doctors, they should be left to do their own. They should follow, recommendations and policies, and stay within the science. But they should be able to think.
Yes. And then, I've asked you this many times. Why isn't your CIN at the national level yet?
I think it should be. The model is there. It can be templated out. I think every CIN needs two people. The one that's the visionary, that thinks up the idea to get people together. But the most important person, I always say, is the second guy that comes in. That's the guy that connects with the first and gets the movement going and gets other people to join. And then once you start the movement, then other people start joining. I mean, I've spoken to numerous people at different states, and I said the template is the same. You can join our CIN, but you guys engage the activities of the CIN in your particular state and how you do it. I mean, what do I really care about what happens in Florida or in New Jersey? I don't even know what happens in Florida and New Jersey. But if we had CINs, I could help them to go and reach out and get value-based contract. You have to go and reach out and get. Doctors feel that they've already done that with medical school, so somebody should come to them and give.
Just that's not going to happen.
It's not going to happen.
I have a little different vision than you do. I think that a national CIN would be extremely important, and it could be in tiers. Yeah. Not everybody has to, because as I understand it in the CIN, let's say, just to throw a payer there, you get a United Healthcare contract on their PPO with a wraparound, and not every practice has to participate in that contract.
Correct.
So I can say, no, thanks, George. I don't want to. I'm out on that one.
Right.
But the more data that we gather together, not only from your practice, but from reports from the insurance companies, what urgent care are the kids going to, what is costing in, amoxicillin prescriptions, who's lagging behind on this or that. The more data points you have, the more you're going to be able to see a whole picture and be able to translate that information to the practices of, this is what's going on at the national level. This is what's going on at your neighborhood net level. Right. And these are strategies that worked in New York to get kids vaccinated for HPV. Here's the template.
Right.
And so that, I think, has tremendous value, improves quality, but it also gets us, to do much better job together. And no one's doing that right now. Everybody tries to reinvent the wheel.
Correct.
I got this IPA, I got that CIN, I'm going to do a group without walls. They're all different avenues that can work, but the name of the game today is data. And, one practice in Long Island, no matter how big the group is, can't compete with Optum, who's got data on physicians throughout the country. And, every darn day they get more data. So they know everything we're doing.
Right. And see, the problem with that is the Optum, for example, a practice that's owned by a big system will eventually force that practice to give up their EHR technology they've been using for 15, 20 years and sign up with their product so they can collect the data.
Yes.
Is that wrong? That's not wrong, I guess. But if the EHR works and the doctors have been using it efficiently for many, many years, and it generates income, why would you want to change? So you have to do something else, get the data out of their system and the other system and the third system and the fifth system, put it into this database, mix it up, and get you the same pretty pictures.
Well, I think from an operational standpoint, it costs money to support these systems. So I have to have an IT department.
Right.
And the IT department gets to the point and saying, I got, Microsoft Windows machines throughout the organization.
Yeah.
I don't have resources to manage Macs.
Correct.
And, so everybody's got to use a Windows machine, whether they like it or not.
Correct.
And that's where they come down. Plus they get discounts. If I buy 5,000 Windows machines from Dell,
Correct.
I get a price break. So I can't be buying from Dell and Lenovo and Apple. I just got to buy from one person to get the price break.
Right.
So that's what happens.
Also.
Yeah. So this has been a fascinating conversation. I know a lot of people are interested. They know how to reach out to you. Your contact info is in our show notes.
Right.
So feel free to contact George if you have questions about this. And keep doing the great work. I think this is very exciting, and hopefully we can take this nationally so we can help independent pediatricians thrive across the country.
I hope so, because we got to make the medicine be a better place, but we have to be at the table. Physicians need to be at the table. They need to show up. Otherwise, they're underneath the table and somebody will serve them.
Yep.
All right. Thank you.
Well, thank you, George. Have a great day.